Evening. Today my presentation is retinal diseases. Actually, what is retina? Come to know about. This is the retina. This is the picture of an eyeball. So what is retina? We come to know about this. My presentation is retinal diseases. Now we are coming to know about what is retina. Retina is the part of brain which lies into the eyes. Our light, when they passes the cornea, lens, vitreous, and then it falls onto the retina, and then it goes to the brain through optic nerve, and then visual sensation will come. So retina is a very important part of eye. Now we are seeing the layers of the eye, and that is cornea, it is pupil, it is anterior chamber, pupil, lens, and vitreous hemorrhage, vitreous, and it is the retina. It is the retina and it is optic nerve. And after that, we are seeing the choroid and sclera. This is the outermost part of the eyeball. Our light comes through the cornea and pupil and vitreous hemorrhage and falls on the retina, and visual sensation goes into the brain through optic nerve. We are seeing the layers of the retina here. We are coming later, details. Now, there is the questions will come that what is the structure of retina? Draw the picture structures of retina. This will come. Now come what are the structures of retina? There we are seeing the overall structures. This is not the details structures, which is histological structures. It is the anatomical structures of the retina. Thus we are seeing the optic nerve, and this is the center part of the retina. It is macula, and it is overall retina. It's equator, and this is ora serrata. We are seeing the vessels which comes through the optic nerve and distributed in the retina, throughout the retina. This is artery and this is vein. Artery lies on the vein. Artery lies on the vein into the retina. This is macula and this is optic nerve. It is also the pictures of structure of retina. We are seeing that this is actually this is diseased retina. We usually always draw the pictures in our clinic to show the retinal hemorrhages, retinal tear, or lattice degenerations, and so on, and other pathologies. But here we are seeing the structures of retina, optic nerve. This is vein. Here artery has not been shown, and this is ora serrata. It is right retina, right side of the eyeball. It is retina of the right side. So optic nerve lies on the right side. Now, the important structure of retina is the macula lutea. What is macula lutea? Macula lutea in anatomy, the small yellowish area of the retina near the optic disc that provides central vision. When the gaze is fixed on any object, the center of the macula, the center of the lens, and the object are in a straight line. In the center of the macula is a depression called the fovea, which contains a specialized nerve cells that are exclusively of the type known as cones. Cones are associated with color vision and perception of fine detail. Toward the center of macula, there are no blood vessels to interfere with vision. Thus, in this area, vision in bright light and color perceptions are keenest. So, it is the important structures that is the center part of the retina, which is called macula retina, macula lutea. This is a very important part of the retina because we are seeing actually we will find details will be seen by the macula lutea of the retina. And cone cells are present in the macula lutea. So it is responsible for color vision and perception of fine detail. We are seeing again the picture of retina. This is retina and this is blood vessels. This is fovea and this is macula lutea, macula. And we are seeing lens, people and so on. Now come to the again to the macular structures. This is fovea. The center portion of the macula is called fovea. It is 1.5 millimeter of diameter, and this parafoveal regions we are seeing that 2.5 millimeter, and overall macula is 5.5 millimeter. It is clinical macula. This again same picture is showing in the fundus. This is fovea, foveola and parafoveal regions, and this is macula. Now what is the diameter of the fovea? 1.55 millimeter. Foveal avascular zone is 0.5 to 0.6 millimeter. It is important for us for retinal clinicians to see the foveal avascular zone is irregular or not in diabetic retinopathy or central retinal vein occlusions and other ischemic diseases. Foveola is 0.35 millimeter. This is the center portions of the fovea. Umbo is also a avascular in the foveal regions. It is only 0.15 millimeter. Now come to retinal structures. The innermost part of the retinal structures, we are seeing that inner limiting membrane or ILM. This is nerve fiber layer, and this is the cells, and the cells are ganglion cells, amacrine cells, and bipolar cells. And how it is formed? Inner plexiform layers. It is formed by the nerve fiber layers of the cells. This is nerve cells, fibers. We are seeing so layer cell. We are coming again, and then it is this is photoreceptor layer, pigment epithelium, outer nuclear layer, and outer limiting membrane, and cone cells also are seeing we are that. So it is the structures of the retina. 10 layers of the retinal structures is showing here, from outside to inside and inside to outside. We are coming again. This is the drawing pictures of the retinal structures. We are showing that is from outer to inwards. That on upper side is outwards and here inwards, layer by layer. Outer plexiform layers, outer limiting membrane, inner flexiform layers, inner limiting membranes. Here we are seeing nerve fiber layers and inner limiting membrane. We're seeing. Here again, this is the picture, pigment epithelium. There is 10 layers of retina, pigment epithelium, rod and cones, outer limiting membrane, then again Muller cells, horizontal cells, how it is formed, bipolar cells, amacrine cells, and ganglion cells, and nerve fiber, ganglion cells, nerve fiber layer, inner limiting membrane. This is the structures of retina. You can, students can draw this. Now come to common diseases of the retina. First of all, common disease, everybody knows that diabetic retinopathy affects eye very much, and affects retina also very much. So diabetic retinopathy is the common diseases of the retina, most common disease of the retina. And then hypertensive retinopathy, because hypertension is more prevalent in our community, so it can also affect the retina. Then hypertensive retinopathy is also common in the retinal disease. Branch retinal vein occlusion, it is complication both of both diabetic and hypertension, as well as other diseases, as can affect the vein conditions and causes branch retinal vein occlusion and central retinal vein occlusion. This is a very site affecting conditions, so we have to treat it as early as possible. Retinal detachment, again, it is a common disease of the retina. Why retinal detachment is common especially in myopic patients, minus power, who are patients, the patients who uses minus power glasses, they usually complain of retinal detachments. And also after trauma, retinal detachment is very common. So retinal detachment is a common disease of retina. Hereditary fundus dystrophies, we are seeing that sometimes the patients are not seeing in dim light. It is a common retinal disease. Fundus dystrophies, not very common, but it is common in our community. We call it retinitis pigmentosa. This is also hereditary fundus dystrophies, and other fundus dystrophies are also common, not common, but it is prevalence in our retinal diseases. So how can we examine the retina? We usually examine the retina by dilated fundus examination. When we usually put the before examination of retina, we usually put dilating drop. What is dilating drop? Usually mixture of pilocarpine and epinephrine, phenylephrine. We are giving before 15 minutes before to for dilating the fundus, 15 to 30 minutes before for dilating the fundus, and we see the fundus by dilating the pupil. By dilating the pupil, we see the fundus. This is the dilated fundus examination. This is the way to see retina through the pupil. And if media is not clear, that's if it is cornea is hazy, and lens is cataractous, and also vitreous is full of blood, and or any other opacities present in the vitreous, so we cannot see the retina properly. Then we can see the retina, not seeing, but we can gauge any pathology is present or not by B scan ultrasonography. Now come to retinal function test. We usually do the Amsler gate. We usually do this to ARMD patients to see any distortion is coming in the visual field. Then uh, this Amsler gate test, light perception test. We can we can perceive the light or not. But if, this is also a retinal function test. And projection of rays. We project light in from different directions and to see which parts of the retina most affected. Photoestress test. We also do two light discrimination test, Maddox rod test, inductive visualization, and laser interferometry. This is not common, but retinal function. We are doing this three tests commonly. And potential equity meter, color perception. We usually see the color perception to assess the function of retina. Now, macular function test. Macular function test. Macula, we have come to know that it is the most important and central part of the retina. So its function to check the function of the macula is very important. How can we check the function of the retina macula? Basic preoperative. We usually see in cataract or dense cataract is present, and so we have to come about the what's macula is good or not, macular function is present or not, or it is proper or not. So we have to check before cataract operation. Refraction one is the to see the macular functions, and near vision also, pinhole vision, Ishihara chart. By Ishihara charts we can detect the color vision. Maddox 2-point discrimination test. It is photoestress test, Amsler gate test. We use already we know about that. Entoptic phenomenon, slit lamp without any opacity present or not in the cataracts in the lens. Dilated fundus, macular pathology present or not. And a special test for fovea. Fovea, we already know that a fovea is full of cones, and so we can assess the frontus of the cones by a special test for foveal functions. Contrast sensitivity, glare disability, potential equity meter, perimetry, optokinetic nystagmus, FFA. It is diagnostic test usually. Fundus fluorescence angiography, BS scan, optical coherence tomography, and electroretinogram, and visual evoked potential. Macular function test with opaque media, that is Maddox rod test, focal electroretinogram, visual evoked potential, laser interferometry, potential visual equity meter test, entoptic phenomenon, and BS scan. That is again, now come to center part of the retina. Usually we have the questions, and what is the center part of the retina, and landmarks of center part of the retina. That is this is optic nerve, macula, this artery and veins, retinal artery and veins. Yes, central retinal artery and central retinal veins are present here. Optic discs, and this is the mid periphery or equator, and it is ora serrata. We're seeing this is a macula, optic nerve. This vortex main is outside the ora serrata. It is retinal periphery, and mid periphery we are seeing that. Major landmarks of retina, that is optic discs, area centralis, including fovea and foveola, and peripheral retina, we already know, ora serrata, and retinal blood vessels. Now, center part of the retina, located in the posterior pole, temporal to the disc, that is macula. Between arcuate and temporal retinal vessels, elliptical in shape, that is macula, 5.5 millimeter in diameter, and corresponds to the 15 degree of visual field. We are seeing that it is macular structures, perifovea area, parafoveal area, fovea and foveola, and tambo. Already we discussed, and again we are seeing that because some questions are coming into the probe, that is what is the central retinal landmarks. This is the picture of central retinal landmarks. Again, now come to retinal diseases. It is diabetic retinopathy. How diabetic retinopathy is formed, we already know that it is when diabetes is uncontrolled diabetes is usually causing the diabetic retinopathy. And diabetic retinopathy is two types. There is non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. How non-proliferative diabetic retinopathy or proliferative diabetic, why it is called non-proliferative diabetic retinopathy? When diabetes is not controlled, and that metabolic end products of the glucose are deposited into the blood vessels and to the vessels of the retina, and this causes the weakness of the retina and secular dilatations of sometimes some parts of the retinal vessels causing, and this called microaneurysms, and sometimes this causes hemorrhages into the retinal structures, and sometimes it can hampers the blood supply to the retinal structures and nerve and also nerve of the retina, that is nerve fiber layer in the retina, that causes cotonool spots. So hemorrhages, cotonool spots, and weakness of the blood causes the diabetic retinopathy, and that is how it's diabetic retinopathy is when it's not very devastating, then we call non-proliferative diabetic retinopathy. Usually we have no proliferative blood vessels in non-proliferative diabetic retinopathy. But macular edema in the center part of the retina, edema or fluid accumulations can be present in non-proliferative diabetic retinopathy. But in this case, we usually present hemorrhages, retinal hemorrhages, exudates, and cotonool spots all over the retina may be present in the non-proliferative diabetic retinopathy, but proliferative vessels will not be present. So what is proliferative vessels? That is new vessels. It presents in the proliferative diabetic retinopathy, where we already know about the pathology of the pathophysiology of the retinopathy, that sometimes diabetic retinopathy causes the or hampers the blood supply of the retina. When it hampers the blood supply of the retina, that where there will be shortage of oxygen supply, and to compensate the oxygen supply, sometimes new vessels are formed. New vessels are formed in the retina, and these new vessels are not good vessels. This is This is very fragile vessels. It can be ruptured or it can proliferate and proliferate all over the retina and can cause traction and can cause membrane formation, and which giving traction to the retina and causes retractional retinal detachment and as well as combined retinal detachment also. So proliferative diabetic retinopathy is a very devastating condition. It is not benign conditions. We have to treat it immediately to prevent to save the retina. And we are coming to the picture. Then we can. Non-proliferative diabetic retinopathy is it's not mild. It is again divided into 4 types: mild NPDR, moderate NPDR, severe NPDR, and very severe NPDR. We are seeing the pictures of mild NPDR. There is some microaneurysm is present and some hard exudates. Mild, that hard exudate present in the posterior pole is the mild NPDR. It's not. This is a case of moderate NPDR. We are seeing the some that's coronal spots and retinal that hemorrhages in all over the retina. We're seeing, and hard exudate also present in the posterior pole. This case of moderate NPDR. It is severe NPDR, coronal spots. We are seeing that it is macular edema is also present and hemorrhages are more than moderate NPDR. This is a severe NPDR. This is showing a pictures, overall pictures. It is mild NPDR, it is moderate, it is severe, and it PDR, and it is vitreous hemorrhage, and it is advanced diabetic eye disease. I'm coming. It is a case of very severe NPDR. Very severe NPDR. It is more than severe NPDR. It is coronal spots and all over the retina hemorrhages are present, which is seems to be proliferative PDR, proliferative diabetic retinopathy. This is a case of proliferative diabetic retinopathy. We are seeing the new vessels over the optic discs. We are seeing it is abnormal vessels. It is formed due to oxygen supply or blood supply to the retina, and to compensate the oxygen demand of the retina, the new vessels has been formed, and these new vessels are fragile and it can form membrane over the retina. And this is also new vessels, that is a networks, and these new vessels form membrane, the membrane, and giving traction to the retina. And in case called tractional retinal detachment, I am coming. This is advanced diabetic eye disease. This is again PDR is divided into PDR and advanced diabetic eye disease. These are the complications of PDR. That's a membrane has been formed, which I am saying that, and form and giving traction to the macula. You are seeing that, and macula is some type of traction. Here it is traction is present, and it is called advanced diabetic eye disease. This is a complication, advanced stages of proliferative diabetic retinopathy. It is also that's new vessels, which I am saying that it is fragile vessels, and it may rupture any time, and if it is ruptured, then subhyaloid hemorrhage between retina and vitreous. There is a space that is called subhyaloid space, and this boat-shaped hemorrhage is usually called subhyaloid hemorrhage. These are complications of proliferative diabetic retinopathy. And again, this is again another complications. This blood has come to vitreous. Vitreous is a gel-like substances which usually lies in front of retina, and the blood has come to vitreous, and we are not seeing the obscure the views of retina. We are not seeing the fundus, only faintly seen, that is vessels, and it is all over the hemorrhage, vitreous hemorrhage. These are complications of proliferative diabetic retinopathy. Now come to hypertensive retinopathy. Hypertensive retinopathy is again divided into grade 1, grade 2, grade 3, and grade 4. This is the overall pictures of hypertensive retinopathy. In grade 1, what is happening? Arterial thickening and tortuosity, arterial tortuosity. We are seeing that increased reflectiveness, silver wearing of artery will also. And grade 2, grade 1 will be present, but constriction of veins. Here we are seeing that artery giving pressure to the vein and constrict the veins. Here, that arteriovenous nipping. We call it arteriovenous nipping. Call it artery. Grade 3, grade 2 will be present, and retinal ischemia will be present. Flame-shaped or blood hemorrhages and the nerve fiber layer of the retina, and coronal spots may be present, and exudate, sometimes exudate is be present in grade 3, but there is no optic disc edema. But in grade 4, sometimes it hampers the vision, and grade 3, all the features of grade 3 will be present, and as well as optic disc edema will be present here. Here we are seeing the coronal spots, retinal hemorrhages, and sometimes here will be macular ester will be present in case of malignant hypertensions, that is grade 4. Okay, now come to today again another topic, so retinoblastoma. Retinoblastoma is a rare form of cancer that rapidly develops from immature cells of a retina, the light detecting tissue of the eye. It is the most common primary malignant intraocular cancer in children, and it is almost exclusively found in young children. Though most children survive this cancer, they may lose their vision in the affected eye or need to have the eye removed. Almost half of the children with retinoblastoma have a hereditary genetic defect associated with retinoblastoma. We are coming details. It is caused by a congenital mutation in the chromosome 13 gene 30q14 retinoblastoma protein. How can we diagnose? Screening for retinoblastoma should be part of a well baby screening for newborns during first 3 months of life to include the red reflex, checking for a normal reddish orange reflection from the eye's retina with an ophthalmoscope or retinoscope from about 30 centimeter or 1 foot. Usually done in a dimly light or dark room. The corneal light reflex or Husber's test, checking for symmetrical reflection of the beam of the light in the same spot on each eye when a light is shined into each cornea to help to determine whether eyes are crossed. Eye examination, checking for any structural abnormalities. Now come to classification of retinoblastoma. The 2 forms of disease are a heritable form and non-heritable form. All cancers are considered genetic in that mutations of the genome are required for their development. But this does not imply that they are heritable or transmitted to offspring. Around 55% of children with retinoblastoma have the non-heritable form. If no history of the disease exists within the family, the disease is labeled sporadic, but this does not necessarily indicate that this is not this is the heritable form, non-heritable form. Bilateral retinoblastomas are common. Unilateral disease or sporadic disease it's not always non-heritable. It may be heritable. Bilateral retinoblastomas are commonly heritable, while unilateral retinoblastomas are commonly non-heritable. In about 2/3 of cases, only one eye is affected, unilateral retinoblastoma. In the other third, and the other two-third, tumors develop in both eyes, bilateral retinoblastoma. The number and size of the tumors on each eye may vary. In certain cases, the pineal gland or the suprasellar or parasellar region, or in very rare cases, other midline intracranial locations is also affected, trilateral retinoblastoma. The position, size, and quantity of tumors are considered when choosing the type of treatment for the disease. Differential diagnosis of retinoblastoma, that is persistent hyperplastic primary vitreous, Coats disease, toxocariasis, retinopathy of prematurity. This is the differential diagnosis of retinoblastoma. We can mimic these conditions, that is persistent hyperplastic primary vitreous, Coats disease, or toxocariasis, retinopathy of prematurity. Now, how can we detect? What are the investigations we can do to diagnose retinoblastoma? Traditional ultrasound BS scan can detect calcifications in the tumor. Usually, calcifications will be present in the retinoblastoma. By seeing the calcifications through BS scan and CT scan, we can detect the retinoblastoma. Traditional ultrasound BS scan can detect calcification in tumor, while high frequency ultrasound BS scan is able to provide higher resolution than the traditional ultrasound and determine the proximity of the tumor with front portion of the eye. MRI scan can detect high risk features such as optic nerve invasion, choroidal invasion, scleral invasion, and intracranial invasion. CT scan is generally avoided because radiation can stimulate the formation of more eye tumors in those with the retinoblastoma 1 genetic mutation, RB1 genetic mutation. What are the treatments of retinoblastoma? First of all, enucleation, external beam radiotherapy, brachytherapy, thermotherapy, laser photocoagulation, systemic chemotherapy, cryotherapy, and intraarterial chemotherapy, and chemoreduction. This is the treatment options of the retinoblastoma. Now we are doing this. Now come to pictures of the retinoblastoma. This is the picture, fundus picture of retinoblastoma. What mom and dad see to the child, that is white reflex. White reflex, where mom and dad can see the white reflex, then doctors see the retinoblastoma. This is the orbital invasions of the tumors in right eye of the child. This is the pictures of retinoblastoma. Okay. Today, I only outlined some retinal diseases, and retinal detachment and other diseases. We also take some details class later on. So thank you.